Steve Quinnan is going to show us deformities of length, and then we'll...
Okay. So let's get started. There's an update on some of the disclosures we mentioned earlier. So thanks for giving me the opportunity to speak about femoral lengthening, and really this talk is a bit more, it's really about limb length inequality and axial translation issues. When we talk about length or talk about shortening, it's interesting because really we're talking about just one aspect of deformity correction. We're talking about translation in the axial plane. So it's one of the 6 sort of fundamental axes you can work around. But in many ways, it's one of the ones that can be the most challenging because there are a lot of limitations put on by the soft tissues, let alone the bones themselves, to allow us to do these techniques. So you'll see some examples here. We've got something that's mainly a length issue, combination of length and malunion, and then finally one that's, you know, quite a bit more complicated. So I'm not going to get back to all these in the talk today, but in our discussion next week and on Thursday, we probably can touch on these quite a bit. So our lessons are, what we really want to be able to do here at the end is explain the indications for lengthening and or shortening, compare the strengths and weaknesses of available techniques for limb length inequality, and to discuss the methods to address concomitant femoral malalignment. Indications. So first and foremost, most of what we're talking about is a limb length inequality issue. They can be post-traumatic with shortening. We've seen a lot of this and we're going to continue to see that. There can also be congenital reasons, so genetic causes, and developmental. So injury to the growth plate during childhood from infection, physeal fracture, whatnot. A couple other things, congenital short stature, so talking about dwarfisms outside of the scope of the talk, but certainly an indication for lengthening. And also bone transport is a special version of lengthening one of the segments of the bone to make up for a bone gap. So the first way that we can gain length, and this really goes back to the lectures that you've just heard, is we can correct an angular malalignment. Just by correcting the angular malalignment, we will gain length in the osteotomy site. You can see that here. I mean, both of these osteotomies are really neutral or closing wedge osteotomies, but we've still gained length just by the process of correcting it. And that's something to remember when we're planning any kind of deformity correction, that there's going to be an effect on length and it's part of our planning process. But there are also osteotomies that are designed with the purpose of adding length. So you see an example here of a Z osteotomy. There are also sliding osteotomies. And fundamentally, you're looking to create a situation where you can extend frequently the shaft segments on each other and provide stable fixation when that's done to get healing. And this can be successful. It's certainly got limitations. The amount of length you can get is smaller, limited both by soft tissues and other concerns. But for a smaller amount of length, couple centimeters, it's an option. Where I really think we put this into context, though, is when we're doing our corrections of a multiple axis problem. You know, we've got a coronal plane, we've got a sagittal plane deformity, and we need more length, but we don't need a lot more length. We need like another centimeter or something like that. Frequently, the osteotomy can be made in a way that can facilitate getting that little bit of extra length to get you perfect. So that's kind of where they fit in my mind. We can also shorten the leg. So if we have a leg with issues, maybe infection concerns, other things, we don't want to perform an osteotomy to lengthen, shortening the other leg is an option. Certainly up to 2 to 3 centimeters is an option. Start to get some functional deficits after that, but for a shorter distance can be good. And we can also shorten the ipsilateral femur if, for instance, the bone was fixed long. So that's certainly less common than a bone fixed short, but it can happen. So when we get to these next devices, because here we're kind of going through some of the devices as well that we have, monolateral rail, circular fixators, we're going to look at all this. We're starting to get into talking about distraction osteogenesis as the mechanism by which we're going to create length. And distraction osteogenesis is without question the most powerful tool that we have to accomplish this. And the original way that we had to do that really relied on this. a Lizaroff fixator. He introduced the concept, and you see here some carbon fiber rings, stainless steel rings. This is on a tibia, but you can use it on a femur. The issue with using this ring fixator on a femur is that although it can be very effective at gaining new length, it's quite bulky around the thigh, and the distance from the fixator to the center of the bone, meaning the lever arm on the fixation, is quite long. So it's more challenging than on a lot of other limb segments when we talk about the femur. Now, some years later, we got the option to use a hexapod, and that certainly made it easier to adjust for malalignment issues that can occur during lengthening, but it didn't fundamentally change the bulk and the challenges related to working around the thigh. That's really why monolateral rails came on the scene. It was to limit that bulk and the difficulty, especially in the femur. And you can see that it really does make a difference here when you compare those devices. The downside is that mechanically we've lost some of our advantage of multiplanarity. Most of the pins are in the same plane. They're all subject to cantilever bending instead of bar bending, which you get with the wires. So mechanically, we've lost a little bit, but we've certainly gained enough in comfort and care for the patient and the physician that probably preferable. That being said, started to look for ways to both shorten the time that the fixator needs to be there, but also to augment the stability to maintain alignment. So lengthening over a nail and lengthening and then nailing are options in this regard. Now, these can be done with a monolateral fixator, and the benefit here is that it does help prevent those cantilever loads into varus that can otherwise occur when we use the rail alone. On the other side, we can nail at the end of lengthening, or in this case, transport. So you see here, there's cables used for the transport, and then it's nailed. Nailing at the end does have advantages in terms of healing when you were transporting bones, but the issue is that we still have the difficulties during the transport with the mechanics. So in the femur in particular, transporting over a nail probably carries some significant advantages that are more so than in other limb segments. That being said, there have been some further developments. So the movement away from using external fixation towards all internal fixation for lengthening really isn't a completely new phenomenon. We've had some devices that have been around for about 20 some years, starting with ratcheting rotational devices. So the ISKD and the Albizia and Betz-Bone-Gachet nails all work this way. Now, these are currently, none of these are available in the United States, but they are used in other parts of the world at present. And fundamentally what they do is there is a rotational mechanism between the two telescopic parts of the nail. So basically the rotation occurs through the regenerate bone, which is not great for regenerate bone. Not necessarily comfortable for the patient, especially the Betz-Bone-Gachet nail, which is a lot of rotation. But it can work, and it's an option. It can't be reversed. There can be other issues, but it was a step forward. Well, now we have available, and we've really had some version available since about 2012, widely in the US, is we have motorized nails. And at present, there's really three options. One is the precise nail, and there are different forms for the femur and tibia. And it's a telescopic nail that's motored by a magnet and an external controller called an actuator. This can be very effective, and it's shown to significantly decrease the complications of lengthening of all limb segments when it's an option, but especially for the femurs. So for straight lengthenings, this is a wonderful development. And then a couple years ago, we had a further development of a different version called Stride that has a much stronger alloy and allows for the patient to weight bear throughout the treatment. So that was an improvement for us. And another nail is available called Fitbone. Now, Fitbone has actually predated all these by a long shot. It was out about 20 years, more than 20 years ago in Germany and at limited numbers of centers, but it wasn't really very widely available up until just the last couple of years. One of the big differences with this is that it is an electric nail. It's not magnetic. But it functions similarly with an external device that drives it. It has a pad, so it could be a little more helpful with some of the deep soft tissues, but it isn't reversible unless you open the patient and reverse the polarity on the driver. So it doesn't have quite the same flexibility as we saw with those other nails. Needless to say, these really are game-changing devices that we now have to deal with length issues, especially length issues in the femur. We also have an option now for internal transport or lengthening of one segment to make up for a bone defect. And that is that we have a bone transport nail. And that phenomenon is really new. That's really only been clinically available in early phases for the last 15 months. So we'll look at a few examples of some of these here. So one, this is a 34-year-old woman. She's 4 foot 10 inches tall, and she's got a 2 centimeter leg length discrepancy. So this is quite a while ago, and at the time, I didn't have the internal nails that we have now. But you see, this is a good example of what lengthening over nails would look like. And if you don't have access to internal nails, which can be much more expensive, this is certainly a way that this can be done effectively. You see the rails put on as remote from the nail as we can, and a gradual distraction there, rate about 1 millimeter a day. And ultimately, within a month, patients out of the frame, we have the nail locked into place, and we go on to see successful healing and that limb length discrepancy adequately addressed. So it's a totally different story. As a guy came to us originally, not to me, but to our institution, and he had an open fracture, treated abroad. Originally, it was given some bone graft to try to get it to heal some. You see that it got a partial union on the lateral side, and there was always a question of infection or not, but nothing really definitive. He clinically wasn't necessarily infected at any point. But we decided he really needed some additional healing on the medial side. So we basically went in and added that at this point, got some additional bone graft, changed the fixation so that the loading would change, and we're able to get that to reasonably incorporate. So we had healed this, but the problem was he had about a 4 centimeter leg length difference. And if I were to have the same injury today or the same problem, I probably would treat it a little bit different. But at the time, certainly encouraged by my partners, and I was relatively younger in my career, we thought it was safest and easiest way to do this would be to shorten the opposite extremity to minimize the difference. So you can see here what we did. It's sort of a chevron osteotomy for shortening. It's about 3 centimeters, done in a clamshell method, as you see there. You can see post-op, we have a nice alignment overall, fixed with a nail, and it goes on to successful healing. Fairly straightforward way to address limb length discrepancy. Now, in this particular case, he went on to heal both sides very well, and he was quite happy. But we did have a little bit of a difference in leg length remaining. It was only about 1 centimeter or so. So he did need a little bit of a custom sole. And if you look critically, there's a little bit of varus and there's a little apex posterior. If I were to do this today, I probably would address all of these and I would use an internal nail on this patient. But certainly there are circumstances where the infection risk would be quite a bit higher. And, you really may want to go with a shortening on the other side as your solution to get those lengths equal. Now, here's another example. And this one is a 34-year-old lady. She had a femur fracture about 4 years ago and abroad again. A limb length discrepancy of just under 3 centimeters, and definitely very bothersome for her. And when you see here, you can look and see that the x-ray looks a little funny. So there was some history about maybe she had an infection. They went in, they took some stuff out, they may have bone grafted. She wasn't really sure what happened, even though she's actually a nurse. And so needless to say, she had no clinical signs of infection. Everything was normal, but I didn't feel totally okay with doing an osteotomy yet. So this is what it looks like, once again showing that we have lucency around the nail, especially distally, but nothing that really blows us away. So I took the nail out in the first stage, and I got cultures and I got some specimens that we could send to the lab to make sure that she was not infected. All of that came back negative. Her ESR-CRP remained good. So we came back, performed an osteotomy, and we used a precise nail, as you see here. to ultimately equalize her leg lengths. She was feeling pretty good when they were only about 4 millimeters different. She was feeling perfect. I had her go another couple after this just because I wanted it to be clearly within 5 different, and she was happy with an extra 2 millimeters after, and went back to work as a nurse in a relatively straightforward time. Now, this was a precise nail, so she had to be non-weight bearing. So the period of time that she was non-weight bearing on this was a bit longer than it would be now when we have weight bearing type devices. So that being said, sort of summary, indications, limb length discrepancy from post-traumatic, developmental, or congenital short stature, as well as bone transporter are all reasons that we may want to change the overall length of the bone segment. Internal motorized nails are really, in my mind, in this modern era, they are preferred when there's not a contraindication based on infection or reasons why a nail can't be placed. They're much easier for the patient. They've shown excellent overall outcomes in terms of alignment that really outperform even what external fixation can achieve in the femur. And external fixation using either a rail or rings is a wonderful tool to have available when we have major infection problems, when an internal device would really be prohibitive. So thank you for your attention.